it's important. The difference between no phones. Okay. Now the difference between nephritic and nephrotic. Right? What's the difference to have something acute or something chronic? It's the difference when you have acute. How do you think they are going to be the symptoms of the manifestations? More abrupt, okay? They are going to be sudden, right? And they are going to be really what maybe send the patient to the hospital. Chronic, remember, is like symptoms maybe not even noticeable, maybe just an incidental finding, but that is important, okay, to decide what are the clinical signs of disease, okay? We talk about laboratory results, but remember, if one of the things, like the most important thing, just to determine what type of renal disease the patient is having, is the biopsy, okay? That is going to be the one making, and in particular is the type of microscopy. And the one, like it was giving, like really the final difference, what type of microscopy was that? The immunofluorescence, because that is going to determine really the true difference, okay? Is in particular when you're talking about the autoimmune, okay, the depositions of the immune process, where they are going to deposit, in particularly in the glomerular basement membrane, right? What are the things, or what is the changes when you are going to have a glomerular injury, right? And what are the type of reactions? What is the body does, okay, to injury? What are the changes on the cell level or in the membrane, like it gets, okay, and that because you have those changes, you are going to have the different clinical presentations of the disease. What is the evolution of the disease? Remember, some of them, they have, with treatment, okay, particularly corticosteroids, the prognosis was great. Which disease was that? Minimal change, okay, because it's the disease. Minimal change disease. The prognosis is usually good. They react well with the patient. But you have a disease like it's similar, okay, in the biopsy to minimal change disease, but the name already is telling you like the prognosis is going to be different, because the changes, they are going to be different as the disease progresses. Yes, okay, say it loud and proud. Focal. Segmental glomerulosclerosis, right? But then you have diseases like they have, okay, autoimmune, but they are going to have also different changes, different deposition, and different clinical manifestations related with that, right? When a disease is primary or secondary, okay? In a few minutes we talk about the primaries. What are the secondary diseases? Which diseases they can have a glomerular disease as a secondary disease? Diabetes, okay, what else? I will not put here high blood pressure on that glomerular, but sickle cell, yes, and one more. Diabetes, systemic lupus. Okay, very good. Primary, okay, remember, most of them look at the key characteristics, like it makes them one different to the other one, okay? Some of them is the prognosis, the treatment. Some of them is the deposition of the autoimmune processes, like they are going to be in different parts. And that what also sometimes if it's inherited or not, right? In the, which one was inherited disease? It's not in this list. Alport, okay, and what is the, if you have to remember a big characteristic of Alport? Yes, inherited is number one. We are going to have other things, okay, because that is in the collagen, right? It's going to be manifestations not only in the kidney, hearing loss, and okay, visual problems, okay, early cataracts or lens dislocation, things like they are not common, right, in younger patients, right? I mean, in general, remember, okay, what's the big clinical presentation, nephritic, nephrotic, what's the pathogenesis, okay, certain things there after an infection. Okay, there's going to be after an infection, could be associated with that, right? And I mentioned before, right, what's the difference in the fluorescence microscopy? We talk about post-infections, right? You have all the different types, okay, the anti-GBM, right? In particular, remember what it was, good pasture, right? If you have, as an example, membranous nephropathy, is it nephritic or nephrotic? What was the difference between nephritic and nephrotic? Nephritic is severe what? Hematuria, right? In nephritic, nephrotic is proteinuria, okay? But high proteinuria, because you can have both, but this is heavy proteinuria. Right, I will talk about this too, okay, we talk about Alport, and we talk about secondary glomerulonephritis, then we have the tubular interstitial diseases. Now you have different parts, the kidney is very complex, you have other parts that can be affected too, right, and what was the difference between something to be, what is the etiology of ischemic or toxic? Okay, one you can have ischemic. What's the difference? Okay, why ischemic? What is that? What? Yeah, exactly. And what it can produce lack of blood supply now to the kidney and to the tubules. Yeah, could be something like that. Okay, but if you're looking for something acute, remember dehydration, okay, or bleeding, extensive bleeding, right? Could be one of the things, okay, because now you're not having, and remember, kidneys, they are extremely sensitive, and in particular are the tubules, right? That it could be whenever you have ischemic or toxic, and when you have the what was ATN, acute tubular necrosis, right? Like the things, okay, remember acute, you're going to have acute renal failure. And this could be, remember some etiologies for toxic. Yes. Okay, and we don't know exactly how much, okay, the people they need to have just, okay, to create that, right? But remember is this part also is of the kidney when you have a lot of the absorption of water too, right? And what's the true difference between ischemic and toxic? Which part of the, okay, tubulars they are going to affect, right? And when somebody has, because you can have the disease, it can be acute failure, but in certain conditions they can be irreversible. Not everybody has irreversible changes. What are the changes on the cells like they make it irreversible? Apoptosis, and apoptosis is sign of necrosis, okay, because you can lose porality, you can have, okay, different things, okay, swelling, detachment, but that is reversible. When you have irreversible is when they start dying, okay, apoptosis, shrinking, the nuclear fragmentation, that it makes it irreversible change, okay? And the end results, okay, what could be certain things as edema could be associated, okay, but what else you have, okay? When you have ischemic or you have toxic, remember they are different parts, okay, of the tubules. They are associated with that, okay? Now, when we're talking about nephritis, okay, tubular interstitial nephritis, again, you have things there, acute or chronic, and you're going to have, again, problems with urine concentration. There could be primary disease, okay? Then what is pyelonephritis, right? What is the type of disease? You have things there, acute or chronic. What is the route of infection? Okay, there are things that are coming from ascending from the urinary tract or coming from the blood, right? Urinary tract infections. And you're also going to have drugs and toxins related with that. Okay, like NSAID, it's here too, right? NSAIDs, okay, remember it's different types of renal injury. What was multiple myeloma? What type of disease? Plasma cells, yes, okay. It's a malignancy, okay, on the plasma cells. And why is here on kidney disease? What's the problem? Excretion of proteins, okay, big proteins, like they are going to be visible on the urine. And what's the name of that proteins? Like that's the hallmark. Huh? Bence-Jones proteins. Okay, that is what they are going to check with that. And also, I mentioned somebody with multiple myeloma. Before they are going to see like the problems on the marrow with the plasma cells, okay, because now you're going to have problems on the renal system. What is going to be taking the blood pressure? How is it going to be? High or low? High or low? I'm putting poker face, you cannot read me. High, okay. It's what is going to send these patients to the hospital besides the multiple myeloma, the multiple punch-out lesions on the bone is not going to send the patient to the hospital. These patients, maybe they will go to the hospital with a renal problem and with this, high blood pressure. Nephrosclerosis and hypertension, okay, this is like really the characteristic for somebody with uncontrolled hypertension is the nephrosclerosis, urinary tract obstructions, where they are, where they can be arise from, urolithiasis, what's that, right, and tumors. Remember, tumors, they can happen also in the kidney, in particularly a pediatric tumor. Which one was that? Wilms tumor, right? And could be both sides, okay, but the prognosis is not so bad. Like it's different with a renal cell carcinoma. For adults, prognosis, it's not good because most of the time when it gets diagnosed, it's easily metastasized. Right, and stages, chronic kidney disease, okay, remember stages, what are the important comorbidities in somebody with chronic kidney disease? Like they are associated also with a chronic glomerular filtration rate. comorbidities. Come on, you were doing so great before. You're losing batteries. Yes, diabetes, hypertension, what else? Hyperparathyroidism comes later, okay? Remember, hypertension, diabetes, anemia, and hyperparathyroidism is coming later on the stages. What are the important clinical manifestations, oral manifestations? What was the bone manifestations on later stages? How it's called? Renal osteodystrophy, okay, and how we make that bones. Weaker bones in any way, okay, you have the visible, okay, radiograph, they're calling that brown tumors, and I show you where are the brown tumors also in hyperparathyroidism, but they are going to have problems with, okay, healing fractures associated with that. And the different types of dialysis, peritoneal and chemo. Come on, here's the question. What is the other type of dialysis? Peritoneal and hemodialysis. All right, and somebody asked the question about antibiotic prophylaxis. When was needed antibiotic prophylaxis in people going? Yes, she's saying no already. Yes, no, because doesn't matter if somebody has an AV shunt or he has, okay, a fistula or any type of communication. I show you the guidelines. What they show is like unless the patient has what problem? Immunosuppression. Okay, and when somebody is immunosuppressed, you can have different situations when you're saying you are immunosuppressed. Huh? Somebody say something like it makes sense. Yes, you are being immunosuppressed when? Yes, transplant because you are taking you have to take immunosuppressants, but not always. You're taking immunosuppressants, but not always immunosuppressed. What in the lab values is telling you, like maybe that person is immunosuppressed? Neutrophils, okay? You need to know the neutrophil count. But you're going to learn more the details about diabetes, okay? We have on Monday lecture for diabetes. Patients with diabetes, white blood cells, they are going to be on the right amount, but they are going to be maybe if it's uncontrolled, they are going to be considered immunosuppressed. And what is the lab test like? It measures the level of control of diabetes. A1C, okay, more than 9, good, she's ready for the clinic. Because that's the things, okay, like the guideline doesn't, okay, recommend the use of antibiotic prophylaxis unless, but that it's common for the non-cardiac condition, okay, is the level of immunosuppression. Like it's not related to the type of shunt or the patient is having, okay? Remember that forever. Any questions? I will not see you until Friday.